Working Public Information Officer. Recently there have been a number of suicides that have occurred in the downtown area. Central Precinct Command and officers are intimately aware of this, and I'm sure you all know also that there was an officer-involved shooting here in the downtown area recently. As a result of that, the Chief Reese, Mayor Adams, as well as Commissioner Fritz asked the Police Bureau to take a look into really information related to suicides. It's not, the media typically does not cover suicides, and so the issue of suicide is really not necessarily in the public eye. And so we began some research along those lines, and it expanded into a discussion around the context of the condition of the system we find ourselves in today, and a little bit about use of force. So we have a draft report that I'll be handing around to committee members, and one of the reasons we're here is to talk with you about the information you'll find contained in it, but we also very much want feedback along these lines from all of you so that we can ultimately finalize this report, delivering it to the City Council. So with that, I'm going to turn it over to Chief Reese, who's going to provide some opening remarks, and you'll hear today from Sergeant Greg Stewart, as well as Dr. Lisbeth Gerritsen and Dr. Daryl Walker of Cascadia, and then at the end have an opportunity for questions. And I'm going to we've got a short timeline here, so I'm going to keep my eye on the clock and do a little bit of air traffic control if that's okay with you. And with that, I'm going to hand out the report, and I'm going to turn it over to Chief Reese.
Thank you, Robert. And again, I really appreciate the co-chairs allowing us to come in today. This has been a wonderful venue for us to have conversations with the community. The Downtown Public Safety Advisory Committee has been a really valuable feedback tool for the Police Bureau, hearing from the community your thoughts and concerns about relevant public safety issues. I know as the Central Precinct Commander, when I worked with this group, how keenly aware you were of the public safety issues in downtown, some of which transcended the downtown area and really have a broader impact on our entire community. Mental health is one of those issues. As Central Precinct Commander in 2007, the Police Bureau saw a significant spike in suicides, to the point that officers were coming in every day decompressing from what they were witnessing and the impact it had on them personally, where they were seeing people in crisis. Often we were arriving after a person had taken their life, and it was shocking to officers. The occurrence nearly every day in downtown Portland, someone committing suicide. I brought that issue forward. We met with our social service partners at Cascadia and at Multnomah County. David Hildalgos, who's here today, was part of that discussion. And we shared information about the system and what's going on. And it was really, I think, the start of a very vibrant relationship with Multnomah County and Cascadia around the mental health system and what we can do to provide the very best and most compassionate care to people in crisis. As Robert said, we had an officer-involved shooting a few weeks ago. Commissioner Fritz and the mayor and I asked our Strategic Services Division to look at some of the factors that are driving this interaction between people in mental health crisis and public safety providers. And so with that, I'd like to turn it over to two of our experts, Greg Stewart from our Strategic Services Division and Dr. Gerritsen, to talk about the research they've done, and admittedly in a very short timeline, because we want to move forward, we want to address the concerns that the community has and provide the very best and most compassionate care we can to people in crisis. So Greg, I'll turn it over to you.
Thank you. As the Chief said, this report initially started out as a review of our suicide activity as it relates to police. It quickly became apparent that we'd need to take a broader lens, and that this would tie into kind of this recurring theme of public safety interactions with persons in crisis. Really quickly, because I'm going to have to move through this fairly rapidly, the report documents my sources, numbers. It's important to be precise, and so that you know exactly what's being said. Don't have the time to do that in this format, so please, look at the end notes, examine the sources yourself, and draw your own conclusions. It quickly became apparent.
Can we circulate the report before you get started?
It's being circulated right now.
Oh, okay.
Yeah. It quickly became apparent that Portland police officers over the last decade are responding to more suicide calls. Suicide calls include attempts at suicide, threatened suicide, or actually committed suicide. Between 2001 and 2011, the number of suicide calls officers respond to nearly doubled. Obviously, that's a dramatic rise in volume, and it speaks to several systems issues that we believe are driving this increase. Similar to the number of suicide calls, we've seen an increase in the total volume of suicides. More recent figures aren't available. However, between 2001 and 2009, we saw a moderate increase in suicides. I think it's a testament to the systems work that is currently being done that we can have suicide calls double, but see a substantially smaller rise in the total volume of suicides. And I think that's important to point out that our partners, while we talk about some systems issues here that hopefully can be addressed, I think it's important to point out the good work that is being done. Any discussion of law enforcement and mental health has to include homelessness. In 2011, Oregon had the second highest homeless rate in the nation, tied with Hawaii and behind only the District of Columbia. I did some other checking, and in 2009 we were third. So this trend has been ongoing for several years. This is important as police interactions with people in crisis because 50% of the homeless in Multnomah County report having a disability, and many of those suffer from mental health issues. And then nationally, it's been estimated that as high as 25% of all homeless suffer from a mental illness. A person suffering from mental illness without a home is most likely going to have increased contact with the police. As the symptoms of the mental illness become apparent, the public's going to call, police will respond to the scene. So any increase in the rise of homelessness will almost inevitably impact the number of contacts officers have with people in mental health crises. In 2004, the Multnomah County Research Division produced a report labeled Canary in the Mineshaft. Probably most folks know this, but I think the analogy they were getting at is miners used to bring canaries into the mineshaft, and as the air quality became poor in the mineshaft, the canary would die. And the idea was that this canary could inform the miners that there was issues with air quality before it impacted them. As early as 2004, Multnomah County was talking about some of these issues. The report noted that between 1997 and 2003, the number of holds investigated by the Involuntary Commitment Program grew by 50%. That number has actually continued to rise. They graciously gave me some figures for 2006 to 2011. And you can see that between 1997 and 2011, holds investigated by the ICP program have risen from about 2,500 to over 4,200 holds. That's a fiscal year, and I've been told they're on track to surpass that this year. This, again, is a very dramatic rise, comparable to the rise the police have seen in suicide calls. And I think it's important, again, as we move forward, that we note that as early as 2004, people have been talking about this emerging issue. I think Dr. Gerritsen was going to discuss some of the issues driving it.
So some of the issues that are driving the increase in the number of holds, and this was noted back in that report of 2004, is the closure of many facilities whose primary mission was to treat folks with mental health issues, mental illness, and substance abuse. So some of these facilities were damaged, of course, that closed in 1995. This was a 375-bed psychiatric facility that closed. After that, the Crisis Triage Center, which was attached to Providence Hospital. It was a triage center. People went there. Police officers, it was 24/7 psychiatric receiving facility. Police officers and others could bring people there who were in an acute psychiatric crisis for assessment and stabilization. That closed in 2001. Then Pacific Gateway closed in 2001 as well as the Ryle Center, which was a small subacute center on Division, about 16 beds. That closed in 2003. Along that same year, Woodland Park Hospital closed as well, and it opened and closed several times since then, but you no longer can take a psychiatric hold to Woodland Park Hospital. So it is no surprise, and it would be naive to think that the closure of all these facilities would not have an impact on the number of holds that would be investigated by the Involuntary Commitment Program in Multnomah County.
This is the number of holds from 2009, and what it is we look at, this is basically 2009 as a cohort, and we look at how many holds we placed on individuals just in 2009. So this isn't since 2009. And what you can see is we placed roughly 1,000 holds in 2009. 11% of those holds, we placed 2 or more holds in the same person in the same year. Some individuals we placed as many as 5 holds on in the same year. And again, these are holds for a mental health crisis, where the officers or project respond workers feel that they're a danger to themselves or others. Again, having to repeatedly place these holds on the same individual is potentially problematic, just in how the individual is being kind of cycled through the system repeatedly. The 2004 Canary and the Mineshaft report found that 35% of all holds were repeat holds, meaning that about 1/3 of the time when somebody is being brought in for a hold, they've previously had a hold on them. So we would expect that over time this number will continue to grow. We're going to go through a little case study. This is one of the individuals who had 5 holds placed on them in 2009. He was a subject we'd been working with the Bazelon Center, and it was a case study we compiled for them, but I thought it would maybe shed some light on this conversation. In 2009, we contacted the individual and placed 5 holds for mental health on that individual. We detoxed the individual 4 times, charged the individual criminally in 19 incidents, and had to use force twice. In 2010, we placed another hold for mental health issues on the individual, 6 detox holds, charged the individual 34 times with criminal offenses, and had a use of force incident where we had to point a taser at the person. Luckily, we didn't have to deploy it. In 2010, we again placed a mental health hold, which I'm going to detail in a minute. Had 16 charged instances, had to use a taser on the person initially. The individual has issues, obviously mental health issues, as well as substance abuse issues. And before we go any further, it's important to note first, most persons suffering from a mental illness are not criminal. They're actually going to be the victim of a crime. About 7 out of 8 about 7 out of 8 criminal acts involving people with mental health issues involve the person with the mental health issue as a victim. So I don't want to paint the picture that this individual is normal. This person is highly abnormal in terms of being criminally engaged as a person with mental health issues. But it is important that we are repeatedly contacting this person. Another important point to note is that individuals with mental health issues who commingle substance abuse issues such as alcohol are more likely to be violent. Again, the vast majority of people with mental illness are not violent. However, if you introduce mental illness and alcohol, much like with the regular population, you're going to have increased violence. I want to detail the last hold we placed on the individual in 2011. Oh, sorry, just to summarize. 7 holds for mental health issues, 10 holds related to intoxication, 69 criminally charged incidences, and 4 use of force. The last hold we placed on the individual involved a radio call of a man with a gun. Officers responded to the scene, contacted the individual, and he began to aggressively approach them, wouldn't follow directions. Officers deployed a taser. During the course of that, actually deployed the taser twice. The individual dropped what appeared to be a firearm, or a firearm actually fell out of their pocket. Officers were able to take custody of the subject without any other incident, despite the presence of what they believed was a gun. They took the subject on a hold. He was eventually sent to a secure care facility. However, 60 days later, the subject left the secure care facility and had to be returned by the police, where again we had to go and track down the subject, find the subject, and return him to the care facility. Given this individual's mental health issues and substance abuse issues, over the last 3 years, to have to contact that individual in excess of 80 times is really inviting tragedy. And again, this individual is not normal. However, I could point out dozens of individuals that we have similar experiences with. So while he's kind of on the leading edge of police contact involving mental health, again, it's not like he is the only person in the system. And kind of what we're hoping in this is that as we point some of this stuff out, maybe we can move forward and find ways to mitigate some of these issues. Dr. Gerritsen?
So we thought it might be helpful. We're talking a lot about holds and putting people on a hold, and what does that mean, and what is the process of a hold. So I'm going to quickly go through this slide, and I apologize in the back. I'm sure it's difficult to read, so I'll do my best to say what it says. So the officer or Project Respond, which is the Multnomah County Crisis Team, places somebody on a hold, and that means they come to the scene and they think, okay, this person is a danger to himself or others, him or herself or others. So the person is placed on a hold, and the officer transports, let's say in this case is Mr. Smith, officers transport Mr. Smith to what are now 5 area hospitals where a police officer can take a hold. So these are hospitals that can receive a hold. So at the hospital, the person goes to the emergency department, that's where you take them, and a doctor decides whether or not you are going to, what we call, continue that hold or drop the hold. So 2 options here, continue the hold or drop the hold. If the hold is dropped, the doctor determines upon talking to the person in the emergency department that they are no longer a danger to themselves or others. So if the doctor determines that in the emergency department, the hold is dropped. So now the process ends. The person walks out of the front door of the emergency department. Nothing further happens, okay? Or the doctor talks to Mr. Smith and decides, yes, Mr. Smith is still a danger to himself or others. Maybe he has a plan, an intent, and means to, say, plan a suicide, or maybe they are out of touch with reality. They are found on the middle of Burnside with a blanket over their heads, not being coherent, maybe psychotic, right? And the doctor decides to continue the hold. They now place what is called a notice of mental illness on the person. That information gets transmitted to the Involuntary Commitment Program. That's this ICP report we've been talking about. The Involuntary Commitment investigators are part of Multnomah County's Mental Health and Addiction Division. So these ICP investigators, they get the paperwork, and literally as soon as possible they go to the hospital. They go to the hospital to investigate this hold. They talk to the person, they find out what's going on, why are you here, what happened. They talk to family members, they do a psychosocial history, they do a psychiatric history, they talk to police officers, they talk to Project Respond, as many people as they can. But it's important to note that this is a very short time frame. This needs to happen within 5 days, actually. So the involuntary commitment investigator at this point in the hospital decides whether or not they are going to continue this hold and send the person to a civil commitment hearing, which is really the treatment of last resort. We have to think of it like that. So the investigator decides, does the person go to a hearing? That hearing needs to occur within 5 business days. Or does the investigator now drop the hold? Meaning they talk to the person, they determine this person is no longer a danger to him or herself and is able to leave the hospital. Now, of course, these investigators attempt to put plans in place, discharge plans in place, so the person is just not going out there. But here's the rub. If the person has no insurance, no OHP, no Verity, which is the mental health part of our OHP insurance, the person has nothing, no private insurance, then this person leaves the front doors of the hospital, and what's the follow-up? What is going to keep that person from coming back? If they want services and they do have insurance, it's completely voluntary. They have to decide to follow up with Cascadia, LifeWorks, Central City Concern. Okay, but if they don't decide to do that, the process ends. If there is no insurance, then good luck. Where are they going to get help? The safety net has been shrinking, and we know that. OHP, budget cuts, etc. So if there's no insurance, then we say the process ends. Until, of course, then here's where we get some of the repeat holds. The person goes into crisis again because what's in place to keep them from that, and they go back into the hospital via a transport hold or an officer hold, and we start the whole process again. Or within 5 business days, the investigator decides, yes, this person needs the treatment of last resort, which is going to a civil commitment hearing. And it's important to note that the civil commitment hearing is a judicial process. Okay, the person goes to Multnomah County Courthouse. There is a judge, big round table, a judge, 2 medical examiners, witnesses, defense attorney, and the judge ultimately decides whether or not the person needs to be civilly committed or not. If they are civilly committed, they are civilly committed for no longer than 180 days. It's also important to note that very few people actually serve out that 180-day civil commitment. The civil commitment average time is more 2 to 3 weeks. A doctor ultimately determines when that civil commitment ends because at the end of the day it is a medical issue. Mental illness is a medical issue. Or they are not committed, in which case the hearing is over and the person walks out of the front doors of the Multnomah County Courthouse, and that's it. They're done. So there's nobody who meets them at the courthouse. There's nobody who says, wow, you were almost civilly committed, but now you're here, and how are you doing? What's going to happen now? There's no program in place. We don't have the people. We don't have the funding. So that's the process. So we show this in order to see at how many places a hold can be dropped, the process ends. And the fact, we're not here to debate the civil commitment process, but what we want to say is if there isn't an array of services, a system of care in place to catch the folks as they either leave the hospital, leave a hearing, or even preferably way before that, then of course these folks are going to cycle through this system. And again, this is the treatment of last resort. Being committed, you are locked. You are forced treatment, and you're locked in a facility. Okay? You can't leave. So it's a very highly restrictive, highly resource intensive last resort. And we have to wonder if we had more services, of course, upstream, wouldn't that be a better outcome also for the people involved? So thank you.
Again, referencing the 2004 ICP report, I think it's important to note that again, as early as 2004, they were calling for improved systems of care for those who do not meet the commitment criteria. Clearly, that hasn't come to pass, as well as looking for filling in the gaps left by the closure of area treatment facilities. There is one new facility that's open, I believe 16 beds, subacute however, so it's not the crisis triage center where officers can take, in fact officers can't directly take individuals there. So some of the gaps have been filled in, I think it's important to note, but I don't think a 16-bed subacute facility is going to replace the array of services that have disappeared since 2001. And Chief, did you want to cover these numbers, or would you like me to?
Yeah, I'll take a little bit of time and talk about our use of force numbers. Because unfortunately, I think, and rightfully so, the public has a vested interest in officer involved shootings as well as the overall use of force. And there's been quite a bit of discussion in the public about our officer-involved shootings and the use of force recently. And you can see from the numbers that they've trended down since the late 1990s. We went back and looked at some data a little earlier. The numbers were fairly similar to 1998. So again, the numbers are, they change every year, but they are trending downward. If we look at how we stack up with other agencies, I think San Francisco, is that, Greg, where this came from?
The San Francisco report, and these numbers are from, I believe, 2005 to 2009.
And in your report, you'll see information about that. But it compares officer-involved shootings across a number of jurisdictions. And again, these are aggregate numbers over several years and show officer-involved shootings in different jurisdictions. You can see Baltimore is at the top end, Long Beach, Oakland in the middle. Portland is down near the bottom with agencies like Boston and San Jose. And then the next one just shows the decline in the use of force overall. I think one of the things that we've done very well the last few years is manage force. And we look at the number of arrests, which have stayed fairly constant, and number of contacts we have with citizens. Approximately 400,000 contacts a year with citizens. And we use force in less than 4% of all arrests, and only in 0.25% of all contacts. So officers are doing a remarkably good job in managing force. When we look at the use of force, all force incidents over the last few years, you can see, again, 400,000 contacts with citizens. We used force in 2008, and 1,600, a little over 1,600. In 2011, it's a little over 1,000. And I'll point out that this includes pointing of a firearm. So out of all of those cases, about half are simply pointing a firearm to control somebody. The other half is what I think most of us would consider use of physical force. So in 2011, we had a little over 1,000 uses of force, and approximately 550 or 600 were pointing a firearm. The others were where we did takedowns, used pepper spray, less lethal munitions, things of that sort. And I wanted to talk a little bit about the things that we're doing in relation to what I would call mental health crisis. And this has been building for a long time in our system and in our city. The Police Bureau, I think, has done a remarkably good job in a number of areas around dealing with mental health issues. As we saw earlier, we had approximately 1,200 suicide attempts that we were dispatched on last year. We took about 1,100 people into protective custody. When our officers get there in time, we make a difference. We save a lot of lives. And unfortunately, there were 111 suicides that were completed last year. I think that if our officers would have been able to get there sooner, we may have saved more lives. Some of the things that we've done over the last few years, again, I believe that the CIT training is a core competency. Based on the information we're looking at and the number of mental health encounters we're having with people, it is really necessary for every officer to have this skill as a core competency in police work. We've had a mobile crisis unit where we've been working with Project Respond in a very collaborative relationship, trying to address the people that are having frequent contact with the police, divert them out of the criminal justice system and into appropriate care. We've developed excellent ties with mental health partners. I think our relationship with Cascadia, Project Respond, and other social service partners is at an all-time high. And I would rather our police officers have that type of relationship with social service partners than with the jail. We're really trying to get people diverted out of the criminal justice system and into appropriate care. The last piece there is a change with the new VCAD system. We have the ability now to do study codes. So when an officer finishes a call, they have to clear it. And in the past, they just would simply say, well, I wrote a report, or I wrote a traffic ticket, or I didn't write anything, I just came, I kept the peace, and I left. Now, with these study codes, officers are documenting what type of underlying issue or issues are at play. So if it's a mental health issue, they document that. If it's a drug or alcohol addiction issue, they document that. If it's domestic violence or gang related. So with study codes, we're able to have a more robust analysis of what's driving our calls for service. And then again, around managing force, we have a force policy that we worked with our community partners on. We've certainly had a lot of discussions in the past year. Our City Attorney, Dave Warbrill, has done presentations to a number of community groups like this around force and the requirements that officers have. We have instituted a new policy that will get supervisors out on force incidents as soon as they're done. So officers are going to call a supervisor to the scene when they've used force. The sergeant's going to do an investigation. That will provide us more information about how we're using force and how we're managing it. We have the Professional Standards Division that has a new inspector's position. I think one of the things that when the Department of Justice came out and looked at our policies and practices, they pointed out to us that we don't have one single person tracking all use of force inside the agency. And so we created an inspector position, and that person now looks at all use of force, whether it comes in through the complaint process, the tort claims process, force reports, or after actions. That person will analyze and look for trends or patterns. They'll also attend the force committee meetings at each of the precincts. We have the city attorney that provides legal updates and talks about managing force at in-service. And then we have an internal advisory group that reviews every tort claim and looks for lessons learned and ways to improve service. So with that, I'm going to go back to our co-chairs, and if you have questions or things. Oh, I'm sorry, Daryl was going to come up. Thank you, Robert.
Sure. I'll make this quick.
You can answer all the questions.
Oh, yeah. Thank you. I was hoping you would give me that opportunity. I'm Daryl Walker, the CEO for Cascadia Behavioral Health. Cascadia runs three key programs, many programs. Three key programs related to this topic are Project Respond. It's a 24-hour, 7-day-a-week crisis outreach program. Works very closely with the Police Bureau. We also operate a 15-hour-a-day walk-in clinic for anybody who wants to see a counselor, a therapist, needs medication to carry over and so forth. And then we also operate a 12-bed crisis respite program out on 70th, and that one is always full. All these programs are very active. One thing I'd like to mention, and it was mentioned earlier, is the Bazelon Institute for Mental Health Law. If you're not familiar with that institute, I encourage you to check them out on the webpage. They are the law project based in Washington, D.C. that advocates for people with mental illness. They've had a huge impact nationally on advocating for mentally ill people with mental illness. They picked Portland 2 years ago as one of 5 sites to study why and how police have contact with people with mental illness. They picked Portland for several reasons. One is we've had a fair frequency of incidences of people with mental illness coming in contact with police officers. But we also are well known for a very collaborative relationship between police bureau, county government, city government, social service agencies, and other community efforts. The other programs are in Austin, Pittsburgh, White Plains, and Detroit. The purpose of the study is not to study police. It's not to blame police or identify police as the problem. The problem is with a system that fails to provide the support and preventative services before a person has the misfortune of being on the streets and having an encounter with a police officer. We've made major progress in finding that. Dr. Garrettson mentioned many of the causes of that. There are a lot of things going on currently to contribute. The incidence, prevalence, increased spike of people with mental illness not in care, the failure to provide indigent health care. Multnomah County is one of the few counties in the state of Oregon that provides additional funding for people that don't have Medicaid insurance. As we know, Oregon Health Plan has cut back significantly on eligibility for Oregon Health Plan Medicaid individuals, leaving a huge gap of people with no insurance at all. I think that's a huge contributing factor to this increasing prevalence of people not in care and needing care. Also, our economy, we're seeing more people, working poor people that are desperate without coverage, as well as just poor people that have no job at all. I think that's all adding to a huge influx of problems on the streets. The unfortunate, amongst many unfortunate outcomes of all this, is that the police officers are the people, for better or for worse, that are the first responders, as opposed to a mental health professional, or even seeing somebody, a counselor in a counseling center. So the police are often out there trying to predict when the crisis is escalated to a point of incredibly intense factors. And in predicting suicide with somebody that is either intoxicated or on particularly stimulants and that are suffering from a major mental illness and have failed to get services, is near to impossible to predict what that individual is going to do. Suicide prediction is one of the more challenging areas in my field. So Cascadia has really reached out. I know Commissioner Fritz has been an active member on Safer PDX, as well as Commissioner Judy Shiprack from the county. There is an amazing group in Portland working with, it's Safer PDX is the name, with the Bazelon Institute here in the Portland area, to identify what are the gaps, what can we do to go upstream and prevent these things from happening on the streets. So, thank you.
Thanks, Darrell.